Hello, this is Miss Pritchard, and I'd like to present spinal cord injury. Within a couple notes within this PowerPoint, there are several links. Those links are to YouTube videos, and I have those links listed on a document where this PowerPoint is posted. I also have some discussion questions over certain slides. They will be represented with an owl there, and there is a document with those discussion points, take-home messages, with the where you can find the PowerPoint itself, and also within those slides, another narrator, Howard, will be going over those. The next slide here lists the online resources. These are posted on Blackboard. These are different than the ones that I have embedded in this slideshow. The Asia exam, we will go over that, and then My Shepherd Center is a very good resource for understanding spinal cord injury. It's pretty comprehensive. There's several videos there, and I think it's a good resource. Then there's sensory and motor assessment. I have one example of a slide board demonstration here, and then there's another one embedded in the PowerPoint. Living with a spinal cord injury, a day in the life. This is a kind of a somber video about this guy's life. Understanding spinal cord injury, the levels. I'm not expecting you all to memorize different levels with different activities. In this PowerPoint, I go over some specific ones that's pretty specific. And then there's conversations from the bedroom, sex after spinal cord injury. Again, this is a bit of a long video, but I think it's rather poignant. It goes into a bit detail and how people successfully cope with their spinal cord injury. Our outline for this PowerPoint, if you want to take a minute here and take a look, I'll be the anatomy, patho, pre-hospital, and then I'm going to present through concepts the acute treatment and then the ongoing assessment and treatment. So I'll go through each individual concept, but in that concept we'll talk about both different categories. Then a short slide on medications, and then the major issue with spinal cord injury is autonomic dysreflexia. Alright, let's talk a minute about peripheral nervous system and autonomic nervous system. The autonomic nervous system is actually part of peripheral nervous system. I know this is probably a bit of a review for you from A&P, but let's give it a start here. Peripheral nervous system is those things that are outside the brain and spinal cord. They include the spinal nerves, you know, those 31 pairs that include your cervical, your thoracic, and your sacral nerves. And they carry information sensory-wise, which would be afferent, going into the spinal cord, up through the cord, and then to the brain. And then motor-wise, that go out, or efferent, those are the ones for motion and activity that go from the brain down the spinal cord, you know, then out to the extremities for motor. Included in that is the cranial nerves, and there's not an expectation that you will know the cranial nerves for this test at this point. With the autonomic nervous system, let's divide that up into two parts. We've got our sympathetic and our parasympathetic. The sympathetic, as you know, is that flight or fight response. I really want to mention the phrenic nerve in there with the sympathetic response, and that would be the cervical 3, 4, and 5. And that's important, and that is the nerves that innervate your diaphragm. That's what helps you breathe. So those people with 3, 4, and 5 injuries have difficult maintaining respirations. So we'll talk more about that when we talk about oxygenation. But you'd think that luckily there's not just one nerve that innervates the diaphragm. There are nerves coming from that, both all 3, 4, and 5 that innervate the diaphragm. Then we think about parasympathetic. That is our rest and digest, or someone mentioned feed and breathe, and I thought that was pretty good. So down to bottom right, those are the systems, that are kind of governed with our sympathetic and parasympathetic nervous systems. So of course the cardiovascular, respiratory, and our thermoregulation, digestion, urination, and sexual arousal here. So really, we don't have a lot of control over those, governed by those sympathetic and parasympathetic. And with spinal cord injuries, there's a disruption there, that many times the parasympathetic will kind of take over when we don't have a real active, intact sympathetic nervous system. So that's where some of our complications come into play. With this slide, we see the parasympathetic on the left and the sympathetic on the right. As I mentioned earlier, there are times when the parasympathetic response is more pronounced. Clients may have a slower heart rate. They're unable to dilate the bronchi like they need to. And you can see the vagus nerve there is higher up near the brain. So you look about, they're in the high cervical areas. Then you look at the outflow there with the sympathetic nervous system, and that's more in the thoracic area. So many times we talk about specific components that happen where people have a T6 or above injury. So the T6 area has the where you can accelerate your heart rate, and many times that people with spinal cord injuries, that doesn't happen. Their heart rate is low. They're unable to breathe well, inability to dilate their bronchi when they need to. So that area of T6 is and above has been impaired, whereas what is much higher, the parasympathetic, that many times is more intact. Right, on this slide, let's look at the central nervous system, and that includes the brain and the spinal cord. And as you know, that's what controls our movements. Our brain says, take a sip of coffee, and it controls our movements. It processes sensory information from extremities, the trunk, and internal organs. And then it relays that information to and from the brain. You can see a picture there in the bottom right, the picture of that vertebrae, and all the bony prominences there, the ligaments, and in the middle there is the spinal cord itself. Right, let's talk a minute about the spinal cord itself. And we have ascending tracts, and these are going from the outer peripheral nervous system to the spinal cord and up to the brain. And with these tracts, there is this is what relays pain, temperature, touch, the points of pressure, shape of an object, and then there's something called proprioception. So just for a minute, if you imagine if you would take something in your hand, say a pencil, and then close your eyes. Now I want you to be able to feel that item. You can tell whether it's hot, it's cold, you can tell the points of pressure, you can feel the shape of that. So know that your ascending tracts are intact. All right. Open your eyes again if you would, and let's talk about proprioception. And that is how the body knows where it is in space. And you can see a picture down in the kind of mid-lower right, and they are manipulating that large toe. So someone without proprioception wouldn't know that that toe has, that toe has been bent, or wouldn't know that the foot has been moved. So they don't know where in space that their body is. So that, in part of a spinal cord deficit, that can be lost. Right. Then our descending tracts from the brain to the spinal cord. This is impulses for muscle movement and needed for mobility. Alright, this is a bit of a busy slide, but it talks a bit about what we just covered with spinal cord injury and the perception of the proprioception, the pain, the temperature, the being able to identify objects. With this, there are different types of spinal cord lesions. The worst one, and the one with the most mortality, is the complete lesion, and that's in the upper left-hand corner there. You can see there above the umbilicus, total spinal cord, it's been severed. So there's total loss of motor, sensory, and reflex activity for that person. And that's probably about 40% of spinal cord injuries are complete lesions. The other types it's kind of a mixed bag. You can see the anterior cord, that Brown-Sequard syndrome, and central cord syndrome. And then there's this cauda equina syndrome. I don't expect you all to know these. Please just know that they exist. The take-home message is that when someone says they have a spinal cord injury, if they say it's complete, then you'll know that they have a loss of motor, sensory, and reflex activity. But if it's not a complete, it can be a really mixed bag. So you need to do a little more assessment there and to see the characteristics of their injury. As I mentioned in the earlier slide, the complete is severed or damaged cord that eliminates all innervation below the level of the injury. So that's about 40% of all spinal cord injuries, not counting the folks that don't make it at the scene. So we'll see no motor, sensory activity, or reflexes below that level with a complete. In the incomplete, that was that mixed bag that we saw in the previous slide. Let's take a minute and look at the primary injury, and they're seeing things such as the hyperflexion, hyperextension, and burst burst injury. So hyperflexion, we might see that if head-on collision there. Hyperextension, if you're hit from behind, and then a burst injury such as falling, and many injuries, cervical injuries, happen from diving incidents. Not just the spinal cord is damaged here, but the vertebrae, the supporting ligaments, and the cord itself. So that would be our primary injury. That's what happens initially. Alright, the secondary injury. So this is what can cause some more significant damage, and it gets worse. So you can imagine there is bleeding at the site of the injury, so you get cellular damage there, and from there becomes edema, then you get ischemia, and then you get more necrosis. Also within that area you have inflammation causes cell permeability. So what normally wouldn't be going in through that blood-brain barrier Now, because that's been broken, you get WBCs and things that shouldn't be within that cervical spinal cord, that shouldn't actually be there, are now kind of, with the cell permeability, are escaping in. Other things that happen within those the spinal cells themselves, those axons, they release some glutamate, and that overstimulation can cause even more damage to the neurons. And then with that more damage there from the edema and the ischemia, you have free radical release, and that can kill the cells that form the myelin that protect the axons, the nerve cells. So again, the take-home message here that yes, there's a primary injury, but now there's that secondary injury that happens where the cord may be further damaged. And that's significant when we think that within the spinal cord there's really nowhere for that edema to go. Think about the spinal cord within the vertebrae itself. So once that injured tissue is going to begin to escape up and down. So you may have an injury at maybe C5, but it can go up several vertebrae. So within that first 24 hours with that edema, it can climb up and affect that C3 level. So, especially when the respiratory system is involved there with the high cervical injuries, we have to be careful with patients within that first 24 hours in this secondary injury. Alright, let's take a minute and look at these fast facts. Trauma being the #1 cause of spinal cord injuries. About 12,000 new injuries per year. Hospitalizations are expensive and fairly long. Who's getting hurt? 81% are young males, and between the ages of 16 and 30. About 67% of those are Caucasian. In motor vehicle accidents account for 35 to 55%, and then falls has really increased also because of our aging population. With the elderly, we have more geriatrics with their spinal degeneration. There's been more spinal injuries from falls now. We've got acts of violence and then sports, and many of these accidents do involve drugs and alcohol. We're looking at penetrating wounds also, gunshots and stabbing can cause spinal cord injuries. And children-wise, we're looking at more or less falls, child abuse is next, and then sports injuries. Alright, so let's look at pre-hospital care. What we want to do is make sure that they have a patient airway, and different with this is that you're going to do that jaw thrust instead of just the chin lift. And there's a little video about that in that upper right hand corner. It shows a bit about that jaw thrust where you're making a C with your fingers and kind of pulling back on the jaw to open up the airway. So the idea is to maintain spinal alignment, and while they're doing that, you're going to go ahead and put on that collar to keep that spine intact. There is a video too about putting on that Laerdal collar, I think, which is helpful. Many times I've seen collars there up on the burn unit. We've had trauma patients and the collar's been on backwards. So it may not be as self-explanatory as you think. Again, as you know from Miss Davenport's lecture, you got the ABCs are oxygen, IV access. You're looking for other injuries there. And then placing them on the backboard. This is real important. And then for spinal alignment. I know in recent years it seemed they're not putting everyone on a backboard. They're being a little more discriminatory with that. and not keeping people on a backboard as long, because it can cause tissue integrity issues. On the bottom right hand page there, it shows children with sports, and if there is injuries there, please leave the helmets on and the shoulder pads on until EMS arrive or appropriate people arrive on the scene. It seems the helmets and the pads are much better than they were years ago, and they help with spinal alignment. So keeping them on until they're evaluated is helpful. Alright, when you get into the ED, things that you want to know is when the accident occurred, and as Ms. Davenport talks about, the mechanism of injury there, immobilization devices, medications and fluids, medical histories, as you know, important. And then making sure that that cervical collar stays on, they're in that supine position, that they're going to stay in a on that backboard until actually released. And so you want to make sure they're transferred on that backboard from stretcher to bed. You want to make sure that you keep that collar on until they're released from providers. There is a good video on log rolling, how important that is. Helpful to have at least 3 people there, even better with 4 as you log roll them, to be able to look at injuries on their back. The diagnosis-wise, we're looking at CT is preferred, and that gives you a good indication of bone-wise what's been injured. Then the MRI for soft tissue, any kind of neurological changes or worsening of neurostatus. And of course that wouldn't be just for in the ED, but an ongoing tests. Alright. As I mentioned, we'll be looking at concepts. They're listed, and through these slides I'm going to talk about the acute and ongoing, and then a little bit of the rehabilitation. So as we progress through the concepts, I'm going to try to talk about each step in there. Alright, let's look at oxygenation in the acute period and then ongoing. I'd like to do an exercise first and think about your breathing. So if you'll close your eyes for a minute, take a really deep breath and concentrate on what muscles you're using. As you breathe in, your diaphragm should lower as the air, goes into your windpipe and expands into your lungs. And then as you exhale, that diaphragm goes on up, and unconsciously you exhale. So try that again. Alright, let's go ahead and examine what happens with folks with spinal cord injuries. So at C1 to C3, usually that whole diaphragm is paralyzed. The intercostals and the abdominal muscles are paralyzed. So anything that would allow them to breathe, there's no innervation. So they're ventilatory dependent. Sometimes on C3 they can spend some time off the vent, but rarely. In C4 and C5, they may be able to spend some time off a vent. The diaphragm partially works, so there's some innervation there. But the intercostal and abdominal muscles, which would help expand, the lungs, help with your respiratory reserve, those are all paralyzed. Things get a little bit better with C6 to C8. They've got the good diaphragm now, but the other muscles, intercostals and abdominal, are not working well. So these people are unable to cough and are unable to sneeze here. So we think about, being able to cough, kind of clear the airway, that's impaired. And with T1, T5, again, their diaphragm works, their intercostals now are fair, and they have a weak cough and sneeze. T6 are looking better. The diaphragm and intercostals are good. Their diaphragm is good, but the abdominal is a bit weak, and they have a better cough and sneeze. So kind of when we look over this, we think about what they're at risk for. You think about pneumonia, you think about atelectasis, especially if they're unable to cough, they're unable to sneeze, unable to take really deep breaths. Think too about the decrease in respiratory reserve, so their ability to really expand their lungs, to take really deep breaths. They're really at risk the higher the cervical injury is. So look, our complications, definitely respiratory failure, especially in the acute setting. We look at, C1 to C5, definitely issues there. We also think about that ascending edema we talked about in the acute phase, that you may have someone that comes in with maybe a C6, but then within that 24-hour period, the secondary injuries happen within that spinal cord, as that edema may go up the cord, so they may end up being a C4 or C3. Hypercarbia, where they're unable to ventilate well. You think about that building up of carbon dioxide, and get some headaches, some dizziness. We think about hypoxia there. And I know you know about pneumonia, atelectasis, and we'll talk about PEs, the pulmonary embolus, risk factor 2, and we'll talk about that a little bit with the perfusion and circulatory issues. All right, in continuing with oxygenation, we have our acute and our ongoing. When we think about tests in the ED, think about what you would imagine being ordered. When we think about ongoing, one of the I thought quick little pearls was that people should be able to count to 10 without taking a breath in the middle. So that might be a good evaluation tool, that they should be able to count without taking a breath. Interventions wise, a lot of this has to do with pulmonary hygiene, and we'll talk about cough assist on the next slide. Suctioning instead of spirometer, percussion and vibration. To do this with caution, especially if how far out they are with that spinal cord injury, how painful it is. But percussion and vibration is important in the ongoing and rehabilitative phase. Think about raising the head of bed, especially if they are on some spinal precautions. And with raising the head of the bed, we have to worry about some hypertension. We'll talk a little bit more about that with perfusion and circulation, but they can become hypertensive if you raise the bed too quickly. Keeping them well hydrated, keeping the secretions thin is helpful. Also look at bronchodilators, mucolytics, and then some ventilatory care. I mentioned in the slide before that ascending edema that we look for usually in the first 24 hours from the secondary effects of following that primary injury. Alright, let's look at the cough assist, other known as quad cough. There's a good link here for two young women who illustrate this, but ideally, as we mentioned, their abdominal muscles are weak or non-existent, and so what you're doing is helping the person cough, expel anything there that needs to come out, and you are just kind of locking your hands there against their diaphragm, and kind of push up and allow them to kind of cough as much as they can, and you become their brace. You got to, of course, make sure that they're in their wheelchair and things are locked and safe before you do this while they're sitting up. Or the video shows them also being able to do this in a reclining position. Alright, our next slide is perfusion in the acute stage. With this, as you know from shock and Ms. Lineberry's presentation, we're looking for signs of decreased cardiac output. Ideally for spinal cord, we want the systolic above 90 millimeters of mercury. If it falls below, the spine area is not being perfused, and so ideally we really want to keep it above 90. So invasive monitoring, central venous pressure going into that right atrium that can monitor preload can be very helpful. Continuous cardiac monitoring there, and then of course you're going to use your IV fluids, going to prime that pump, use your vasopressors. Norepinephrine is, I think, better than dopamine. Dopamine can cause some issues within the spinal cord itself. So norepinephrine or Levophed is usually the drug of choice here. Alright, let's take a minute and look at neurogenic shock. And this is a perfusion issue. It occurs more often in people with a T6 and above spinal cord injury, and happens many times in that first 24 hours. As we talked about before, after that primary injury, there was that secondary injury that involved the neurons and the cells itself, themselves, and it seems that that disruption in the nerve cells and that increased risk of that glutamate may be responsible for this neurogenic shock. And the sequela of this is there's a loss of normal, damn, Bernice, let's take a break. Alright, let's examine perfusion from acute and ongoing. With spinal cord injury, they have a propensity for DVTs, for emboli, and for pulmonary embolus. We ideally want to prevent this. We can do this with low molecular weight heparins, such as Lovenox, or the new POs, dabigatran, rivaroxaban. These are PO drugs. They're a bit more expensive, but you don't have to do blood levels like you would with our warfarins. The new normal for spinal cord injuries, especially those with T6 and above, their systolic blood pressure is much lower. It's like between 90 and 110 is more like the average. And keep that in mind when we talk about autonomic dysreflexia in slides to come. They have issues with orthostatic hypotension, as you can imagine, because of the lack of nervous intervention with the or innervation into the vascular system. So those veins and arteries are less taut, blood is more likely to pool, so that sympathetic innervation is lost. So if you raise the head of the bed really quickly, you drop their legs quickly, they're more likely to experience some hypotension. Alright, let's look at neuro-wise, in the acute care and the ongoing, and these are very similar, the tools that you're going to use. You'll use your Glasgow Coma Scale in both, level of consciousness, and motor and sensory assessment, and we'll go more specifically over in those. Please be familiar with your Glasgow Coma Scale and how to use that. One of the specific things for the acute care is spinal shock, and the next slide will go over that more specifically. With our trauma patients, we do have to look at level of consciousness issues, whether they have signs of ICP or any kinds of concussion. So please review your ICP. Spinal shock is specific to spinal cord, and what differentiates this, it is not a perfusion issue. So it's much different than neurogenic shock. It's not perfusion. What may cause this is that secondary injury that we talked about earlier, where there is cell damage, where there's ischemia, where there's that glutamate being released from the cells, and it's causing cellular imbalance. They attribute that to spinal shock. And it's 50% of people with spinal cord injury fall victim to this. And it's interesting that below the level of injury, people lose all voluntary and reflex activity. So suppose you have a T4, which is like at the nipple line. There'll be no movement, no sensation, not able to move legs, not able to feel, no pain, no deep tendon reflexes below that level of injury. So there's flaccid paralysis, no deep tendon reflexes, there's urinary and bowel retention, and no sensation. For most people, it begins within an hour and it resolves within 48 hours. And interesting, as you can imagine, that you really don't know what kind of spinal injury they have until this kind of resolves. So you don't know whether it's a complete or incomplete spinal lesion unless this resolves. And it resolves rather slowly, usually within 48 hours, sometimes up to 6 weeks, but that's not the norm. And they have a gradually return of their deep tendon reflexes. Unfortunately, many people see that return, and there may be some spastic activity, and they'll take that to mean that there is some purposeful movement there. So we don't want to give anyone false hopes with this spastic return of activity. Alright, let's look at our treatment for spinal shock. And it is symptomatic. If it is a high level of injury, we'll have to do some ventilation. They may be required a ventilator. They may have some hypotension there, that you may need some pressors. There may be an issue with some bradycardia, maybe a little atropine, but usually that is not the case. They will have an atonic bladder, and it will become overdistended, that they have no control over the sphincter release, so the bladder will just keep filling. So they definitely need a Foley cath. They may have a paralytic ileus too, so we'll have to place an NG tube for that, Salem sump to suction. And as I mentioned, you can't classify this until this spinal shock has resolved.